Dear colleague, chairman, from 2003 to 2015, our standard practice at our institution was for mitral valve repair or replacement, the right lateral mini thoracotomy. Then in 2015, we switched to further reduce the surgical trauma to a full endoscopic approach, as you can see in periaurial fashion in men and submammary groove without respreading for the women. To compare these two highly inhomogeneous groups, we developed a propensity score matching 1-to-1, and we came up with two comparable groups, 105 patients each. As you can see, the p-values are equal. And then, not only from a point of view of the duration of the surgery, the anesthesia, the cross-clamp and then CBB time, they were comparable, but also the repair rate were statistically equal, but if you see, is quite higher in the non-rib spreading group. Also, all the other postoperative features are equal, and as a hospital stay and the discharge home rate is about to be higher. Also, we thought to explore the well-being of this patient after the operation, namely only in non-rib spreading, using the SF12 assessment score. They both physically and mentally were slightly better. And also we explored the learning curve of this procedure by using Kusum curves. As you can see, this is a clear learning curve effect, even in probability of failure, but also in the surgical setup, CPB duration, and cross-clamp time. In the very end, this approach is not only feasible and comparable to a standard approach at the plateau or the experience, but it's also reproducible, learnable, and gives equal results. Thank you.
Thank you very much. Now this paper is open for discussion. Are there any questions from the audience? I think it's very difficult to do the endoscopic surgery from the beginning. You know that you show that's the learning curve. Myself, I studied the endoscopic surgery by a Da Vinci robotic system. It takes about 7 to 8 cases for to accustom to the endoscopic surgery. So how about the endoscopic surgery? Your endoscopic surgery is not using a robotic system.
No.
So
for sure, the first cases we had to adapt from the thoracotomy with the wrist spreader to a very small incision that fits only the instruments, and the endoscope should be not in the way of the instruments. So, but as you can see, about 50 cases are necessary to reach the lower boundary for the learning curve, and there are some failures. But it's not so difficult, maybe because we were well trained before that amount of surgery in a minimal invasive. So everybody needs to adapt their own practice with a different recipe, maybe for endoscopic. We use a Cheatwood clamp, some other use a dedicated clamp in the same incision, some other could prefer the endo clamp. So,
and how many surgeons are working in this group?
This group is consisted by 3 surgeons.
And when you say 50 as a learning curve, is 50 for all the group?
There is a splitted routine for everybody. The chief is doing the main part. We are doing all the preparation, and so is really a learning curve of each one, because we are all involved in the same steps.
And there is a very nice paper by the Leipzig team where they saw the learning curve of different surgeons, and each time you had a new surgeon, you saw the learning curve, the results which deteriorated and after they increase. And the conclusion was that at least a surgeon need to do 2 minimal invasive procedures per week if he wants to get the best level. What is your conclusion in terms of activity per surgeon?
I think this learning curve has we have to adapt at first, and our policy is usually to give a small group a new task, then develop and pass this learning curve, then the routine can be adapted to all the others. So we are training one surgeon for the routine, then other surgeon in the future.
Okay. Any question or comments? Please wake up. Okay, so thank you. If there is no more questions, thank you for your participation.